Good morning, everyone. So let's study polyps, polyps of intestine. So what is polyp? Any focal lesion that projects above the surface of the surrounding mucosa is a polyp, and it is classified as sessile polyp, pedunculated polyp, flat, and depressed. So what are sessile polyps? Sessile polyps are polyps in which base is attached directly to the GIT wall, and the pedunculated polyps are polyps in which the mucosal stalk is interposed between polyp and the wall. So basically, pedunculated polyp is a polyp with a stalk. Then flat polyp. In flat polyp, height is less than one half the diameter of the lesion. And fourth one is depressed polyp. Depressed polyp likely to harbor high-grade dysplasia or malignancy even if it is small. So polyps are divided into two categories mainly: non-neoplastic polyps and neoplastic polyps. Non-neoplastic polyps include hyperplastic polyps, hamartomatous polyps, juvenile polyps, Peutz-Jeghers polyps, inflammatory polyps, and lymphoid polyps. And these juvenile polyp and Peutz-Jeghers polyps are under the category hamartomatous polyp. So, non-neoplastic polyps are hyperplastic polyps, hamartomatous polyps, inflammatory polyps, and lymphoid polyps. And the neoplastic polyps are adenomas, which are benign polyps. So this picture is depicting sessile polyps and pedunculated polyps. Polyps which are directly attached to the wall without any peduncle, and pedunculated polyps which have a stalk or peduncle. Now hyperplastic polyps. They are most common polyps of gut and usually multiple or maybe single, attached with a stalk and lined by normal mucosa. Hyperplastic polyps are mostly less than 5 mm, but they can reach up to 2 centimeters. Microscopic examination of hyperplastic polyp show well-formed glands and crypts lined by non-neoplastic epithelium. So it is a microphotograph of hyperplastic polyp. You can note the serrations. Hyperplastic polyp has serration and various types of epithelial cells. Now the hamartomatous polyp. What is hamartoma? Hamartoma is defined as localized overgrowth of a single tissue or combination of tissues indigenous to the affected body part or organ. So it further includes Peutz-Jeghers polyps, juvenile polyps or polyposis, Cronkite Canada syndrome, and Cowden syndrome. So coming to Peutz-Jeghers polyp or Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is an autosomal dominant syndrome and it has mucocutaneous melanin pigmentation in association with multiple GI hamartomatous polyps and extraintestinal benign as well as malignant lesions of breast and pancreas. So basically, the syndrome includes hamartomatous polyps of GIT, mucocutaneous melanin pigments, and benign and malignant lesions of breast and pancreas. Males and females are equally affected and disease occur mostly in second to third decade of life. Symptoms include abdominal pain, GI bleeding, and obstruction. Most common locations of polyps in GIT is small intestine, then colon and stomach. Polyps measure so number of polyps may vary from 1 to 20 and measures 0.5 to 3 centimeters. Now the common mutations which leads to Peutz-Jeghers polyps are STK11 mutation or LKB1 gene mutation. Carcinomas are more likely to arise in patients with familial form due to acquisition of additional mutations like TP53 and beta-catenin gene mutation. So, the gene mutations involved in Peutz-Jeghers syndrome is STK11 and LKB1 gene. So, this is a gross picture of polyp showing multinodularity on external surface and a peduncle. Now the microscopy of same polyp showing bundles of smooth muscles that forms the thick stalk and the mucosal glands. So Peutz-Jeghers polyp has characteristic feature of smooth muscle bundles. These are the smooth muscle bundles along with mucosal glands, tubular mucosal glands. Next is juvenile polyps or juvenile polyposis. It could be isolated polyp, isolated juvenile polyp, or juvenile polyposis of infancy, juvenile polyposis coli, or generalized juvenile polyposis. The isolated form and juvenile polyposis coli occur in rectosigmoid region. Now the juvenile polyposis syndrome. Most common GI hematomatous polyposis syndrome. It is the most common GI hematomatous polyposis syndrome, and generalized polyposis complicated by GI bleed, diarrhea, rectal prolapse, and protein losing enteropathy. Abnormality in signaling pathway of TGF-beta via genetic mutation in DPC4 SMAD4 gene. So, the genetic abnormality is gene mutation in DPC4 and SMAD4 gene. So, diagnosis can be made by family history of juvenile polyposis syndrome with any number of polyps, or polyposis involving the entire GIT, or 3 to 10 juvenile polyps. Dysplasia in 30% of polyps of juvenile polyposis syndrome, almost never in isolated polyps. So, dysplasia is common in juvenile polyposis syndromes and not in isolated polyps. This is the photograph of gross appearance of retention polyp or juvenile polyp, and this is the micro photographs. Grossly, it has hyperemic surface, and on microscopically, it has cystically dilated glands. These cystically dilated glands are characteristics of juvenile polyps in an edematous stroma. Cystically glands in an edematous stroma. Now another syndrome, Cronkite-Canada syndrome, non-hereditary. It is non-hereditary syndrome, generalized polyposis disorder that involves any part of GIT except esophagus. Etiology is unknown, and numerous GI polyps are associated with alopecia, vitiligo, skin pigmentation, and nail atrophy. Risk of malignancy is 20% and mortality is 50%. Then Cowden syndrome. It is an autosomal hematomatous syndrome characterized by mucocutaneous stigmata, GI hematomatous polyps, and increased incidence of malignancy in various sites. Germline mutation in P10 gene. So remember, gene involved is P10. Hematomas in Cowden syndrome affects all three germ layers. GI polyps seen in 30% of the cases. Stomach, small intestine, and colon may be affected. Esophagus has glycogenic acanthosis, means epithelial polyps with cells containing intracytoplasmic glycogen.